Good evening, dear friends. At the outset, I would like to thank iTrue Group and Dr. Ananda for this opportunity. I will be talking about evaluation of male LUTs. I am Dr. Tanushpal Bhatia from Faridabad, India. So we know that LUTs is a term that covers symptoms that result from conditions and diseases affecting the bladder and the urethra. These can be storage symptoms like urgency, urgent continence, frequency, and nocturia, or voiding symptoms like interrupted stream, terminal dribble, hesitancy, and straining. And they can also be post-micturition symptoms like dribbling or incontinence and sensation of incomplete voiding. The recently released Indian guidelines, they define LUTs as a variety of symptoms of storage failure, voiding failure, and post-micturition symptoms that result from a variety of complex and dynamic interactions between the bladder, prostate, and urethra, as well as the result of several systemic diseases and neurological conditions. We know that there can be several causes leading to lower urinary tract symptoms. This can be the most common benign prostatic obstruction, or overactive bladder, or nocturnal polyuria, underactive bladder, pelvic pain syndrome, neurological causes, foreign bodies, urethral strictures, ureteric stones, etc. So we know that LUTs affects the quality of life. More severe the LUTs, worse is the quality of life. And it has also been seen that when intervention is done in form of medical therapy or surgery, as the LUTs decrease, the quality of life improves. Coming to evaluation of male LUTs. So we know we always start with a medical history. There should be a focused medical history assessing the symptoms of the patient. We should ask the patient the medications he has been on. We should also assess for other medical and neurological diseases, and we should assess the social and psychological factors. This has a strong recommendation from the EU guidelines that we should take a complete medical history for men with LUTs. Now, coming to symptom score questionnaires. All guidelines recommend using validated questionnaires. Symptom scores are helpful in quantifying LUTs and in identifying which type of symptoms are predominant. However, they are not disease specific or gender specific or age specific. IPSS is the most commonly used symptom score for LUTs. AUA SI was adapted by WHO, and element of quality of life was added and labeled as IPSS score. The limitations of IPSS are that it lacks an assessment of incontinence, post-micturition symptoms, and the bother caused by each separate symptom. Also, IPSS score has to be translated to different language and validated. This is another questionnaire which is used, ICIQ MLUTs. It contains 13 items. It is a more detailed questionnaire covering hesitancy, straining, strength of stream, intermittency, incomplete, emptying, urgency, urgent continence, stress incontinence, unexplained incontinence, nocturnal enuresis, post-micturition dribble, nocturia, and frequency. Its validity, reliability, and responsiveness has been established. However, in India, this symptom scale is not commonly used. Coming to visual prostate symptom score. Many men require assistance to fill up the IPSS forms, especially in the subcontinent where the literacy level varies between different patients and many are actually illiterate. And IPSS also has to be translated to many languages requiring separate validation. So Vanderwalt et al. Developed a visual prostate symptom score in form of pictograms, which can be filled by patients with different level of literacy. And Roy et al. Validated the VPSS in Indian rural population and found it to correlate with IPSS. This is the VPSS score on left side, and on right side is the improvised VPSS score by Dr. Venugopal sir and group, wherein they have defined severity based on the score achieved between mild, moderate, and severe. So all the guidelines, as I said, recommend using a symptom score. They recommend that you should use a validated symptom score questionnaire, including the bother and quality of life during assessment of LUTs, and also for re-evaluation during or after the treatment. Regarding frequency volume charts and bladder diaries, there is a strong recommendation from EU guidelines to use bladder diary in patients with male LUTs with predominantly storage component of symptoms or nocturia. And patient should be asked to complete the bladder diary for at least 3 days. Coming to physical examination, it is very important that we should physically examine the patient. One should examine the suprapubic area, the perineum, the external genitalia, the digital rectal examination, and the lower limbs. One should also look for any urethral discharge, phimosis, meatus stenosis, or penile lesions. Digital rectal examination, one should look for the prostate size, consistency, tenderness, and anal tone. There are different ways in which it has been described that the size can be assessed. One such way is shown in this diagram where the fingertip is compared to about 10 gram of tissue, and multiples of that can be assessed for assessing the prostate size. However, it has been seen that it does not really correlate well with the truss volume or the resected prostate volume. So there is a strong recommendation from the guidelines to perform a physical examination and DRE in patients with LUTS. Now, a resident should know what is an abnormal digital rectal examination. So we call it an abnormal DRE when there is a nodule. It can be a hard or a firm nodule. When the prostate is hard in consistency, when there is irregularity of the surface of prostate, if there is any fixity of the rectal mucosa, and if there is asymmetrical enlargement, one lobe is enlarged more than the other lobe. Now, coming to the investigations that we do, urine analysis is a cheap and easily available investigation. It helps us to identify issues like UTI, diabetes, and hematuria. And there is a strong recommendation that urine analysis should be used in assessment of male LUTS. Coming to prostate-specific antigen, PSA has a good predictive value for assessing prostate volume. The potential benefits and harms should be discussed with the patient. Only then we should order a PSA test. Most guidelines recommend a PSA test if PSA is going to change the management plan and if the life expectancy of the patient is more than 10 years. So same as the recommendation from both Indian and European guidelines that it is a optional test in evaluation of male LUTS, and it should be done if it is going to change the management plan and if the life expectancy is more than 10 years. Now coming to renal functional assessment, renal function may be assessed by assessing the serum creatinine or EGFR. Hydronephrosis, renal insufficiency, or retention are more prevalent in patients with BPH. Even though BPO may be responsible for these complications, there is no conclusive evidence on the mechanism how it affects the renal function. If a patient has a poor flow and he has a history of hypertension and diabetes, then there are more chances he will be having associated CKD. And the patients with CKD are increased risk of developing post-operative complications. So the guideline recommendation is that the renal function should be assessed if renal impairment is suspected based on history and clinical examination or in presence of hydronephrosis when considering surgical treatment for male LUTS. Now, coming to uroflowmetry, it is widely used and a non-invasive test. Poor flow can arise as a consequence of bladder outlet obstruction, detrusor underactivity, or an underfilled bladder as well. Therefore, it is limited use as a diagnostic test as it is unable to discriminate between the underlying mechanism. It can be used for monitoring treatment outcomes and correlating symptoms with objective findings. So there is a weak recommendation to perform uroflowmetry in initial assessment of LUTS, but there is a strong recommendation to perform uroflowmetry prior to any medical or surgical invasive treatment. Coming to ultrasound, this can be in form of transabdominal ultrasound, transrectal ultrasound, or a post-void residue assessment. Ultrasonography is widely available in India, although bladder scanners and catheters are not routinely used for PVR assessment. Upper tract evaluation is warranted when there is a large PVR, correlation of raised PVR and UTI, and severity of LUTS is not clear with ultrasound. There is little correlation between PVR and bladder outlet obstruction. It is commonly stated that TRUST is more accurate than transabdominal ultrasound in predicting the volume of adenoma enucleated during open surgery. TRUST has a better role than DRE in estimating the prostate weight. It is also now becoming more and more important to assess the intravesical prostate intrusion. It can be graded as mild, moderate, or severe based on the level of intrusion of prostate into the bladder. The Korean and Singapore guidelines recommend measurement of IPP on ultrasound. It has been seen to correlate with the degree of prostatic obstruction, the likelihood of failure of trial without catheter, and also with progression of BPH. These are the recommendations from guidelines. If I talk about Indian guidelines, they give a conditional recommendation to measure PVR in men with LUTs. They give a conditional recommendation to perform ultrasound for upper tract in men with LUTs. But because it is widely available, it is commonly used in India. The prostate ultrasound for prostate size is optional if it will change the medical management. And there's a strong recommendation to perform prostate ultrasound before deciding on the surgical management of BPH. Then there are other imaging modalities like CT and MRI, which are rarely used in initial evaluation of LUTs. Avoiding cystourethrogram is to be performed if you are suspecting that patient can have reflux or diverticulum or a urethral stricture. Cystoscopy should be done in patients with microscopic or gross hematuria suspected, history of microscopic or gross hematuria, history of urethral stricture or bladder cancer who present with LUTs. They should undergo cystoscopy during the diagnostic evaluation. None of the studies have found a strong association between cystoscopy finding and urodynamic finding. While urodynamic study is a better way to diagnose bladder outlet obstruction, it is not widely available in India, and cystoscopy is used by many to assess the bladder outlet obstruction. From EAU, there is a weak recommendation to do cystoscopy in initial assessment. In the Indian guidelines, there is a conditional recommendation to perform cystoscopy if it may change the plan of action, to perform cystoscopy before any planned surgical therapy, and to perform cystoscopy for diagnosis of bladder outlet obstruction when UDS is not available in the facility or in the neighboring centers. And there's a strong recommendation when to perform cystoscopy in men with LUTs if they have hematuria, suspected stricture, or suspected bladder cancer. Urodynamic study in male LUTs, the most widespread invasive urodynamic studies employed are the filling cystometry and pressure flow studies. It does help us to differentiate between detrusor underactivity and bladder outlet obstruction. It also identifies detrusor overactivity, which is important in patients with predominantly storage symptoms. Due to invasive nature of the test, UDS is generally only offered if the conservative treatment has failed. Routine use of UDS in evaluation of uncomplicated LUTs has limited role and should be used only selectively. And also there should be a rigorous quality control when at the centers where UDS is being performed. So these are the recommendations. So this flowchart basically summarizes the evaluation of male LUTs. We have to start with a good history, which should include assessment of sexual function, use of symptom score questionnaires, urine analysis, and a physical examination. PSA should be discussed with patient and then ordered, or if there is a suspicion of CA prostate, and a measurement of PVR should be done. If the PVR is significant, one can assess, get an ultrasound of the kidneys and get a renal functional assessment as well. And then you can decide whether you need a uroflowmetry or a urodynamic study, or you can start with the non-medical or medical treatment for patients. Thank you. I would like to again thank you, ITRO Group, for this opportunity.